All right, so this is a recording for UW Oshkosh Doctorate of Nursing Practice Program. This is Carissa Meyer. We're here today to talk about sports medicine. So thank you for coming on and speaking with the students and taking some time to do this. So tell me a little bit about yourself and kind of what got you into sports medicine, a little bit of your background. And
Sure. I'm a UW Oshkosh graduate myself in 2011 from the Family Nurse Practitioner program, the Master's. And I initially started out in pain management, transitioned to sports medicine / orthopedics in July of 2014. So about just over 6 years now. Currently work at OSI in Appleton as a float nurse practitioner between clinic, surgery, walk-in clinic, the whole gamut. So it's a very wide variety. We see from orthopedics to standard total hips, total knees, sports medicine, from ACL injuries to rotator cuff repairs, kind of the whole gamut, fractures.
what's your favorite part about what you do?
I do like to see the patient before, like what the initial presentation was for the injury or the cause of the issue. I love assisting in surgery. And I think it builds a rapport with the patients when you see them post-operatively that you were in the surgery as well. So when you're explaining the pictures to them, if there's operative pictures, from scope surgeries, they just have that extra sense that and the trust when you're explaining to them because you were in the surgery itself as well. So.
Anything that's really challenging or difficult about what you do?
I don't know what the biggest challenge is. Probably patients that want to have surgery or think that surgery is the fix and the answer right away when that's probably not in their best interest. And trying to truly explain that to them can be kind of a challenge.
Sure.
Or patients that come in, we can give them every recommendation, and I don't think this just goes for sports medicine, of evidence-based practice and what's probably best for their condition. And they either just want a pill to make it go away, or they don't want to do any of that, but they still want it to get better. So if you recommend physical therapy, they don't want to participate, but then they'll come back and say, well, it's not better. So that's probably one of the biggest challenges.
Sure. Yeah, absolutely. Well, good. Well, I'm excited to kind of talk with, the goal for today is really to kind of talk about common orthopedic issues and sports medicine issues that you see and kind of give, students a good idea of kind of common management and when not to refer. So I think we'll just kind of start talking, body systems. So the first one, shoulders, if you want to kind of talk through shoulders and your evaluation and treatment. And
probably some of the most common things you'll see in primary care for shoulders, I would think would be rotator cuff tendonitis or an impingement syndrome. Rotator cuff tear is pretty common. Labral tearing in the shoulder, depending on the population, if it's an acute versus a degenerative or a wear and tear over time. Calcific tendonitis can be one that will pop up sometimes where probably the differentiating factor for that, calcific tendonitis, is usually that middle-aged, more commonly women, sudden onset of pain, woke up with it. It almost presents like a rotator cuff tear as far as the degree of pain, maybe some restrictions and weakness, but they had no injury. And that just doesn't typically make sense. You can get an x-ray of the shoulder and you'll see a calcific lesion on there that will explain it pretty well with just a basic x-ray. No need to go get an MRI or anything like that right out of the gate. So in that scenario, just like a rotator cuff tear, that is going to be many a times acute injury, falling on an outstretched arm, trying to catch something as it's falling. That kind of thing can tear a rotator cuff. Most of the time they'll present with night pain is going to be a red flag. Does it wake them up at nighttime because they have pain? And weakness, true weakness, not just because of pain. So the best way I explain it to patients is it probably hurts to lift your shoulder up, but if I took away the pain, do you think you could do it? If you go across monkey bars and you have a blister, you can still do it, but it hurts because of the blister, but it's not like you're weak. It's just, you can't do it because of the pain. So sometimes it's hard to differentiate that. But the range of motion is good. What they can do themselves for active, but what you can do as passive if you lift their arm, can they get it there? If they're restricted in their range of motion truly, and it's a hard stop, then you might be looking at that frozen shoulder type diagnosis.
Okay.
But night pain is going to be a big deal for a rotator cuff tear along with an injury typically.
Okay. Yeah. How about the labral issues?
Labral issues might get clicking, popping, certain degree. If they're doing external rotation laying down, that's going to put a little bit more pressure on the labrum. Younger athletes might have an acute labral tear, either from if it's posterior versus anterior. The labrum is what goes around the glenoid to kind of give a bumper to keep that shoulder in there, or the humeral head in there. But labral tearing, kind of the difference when you see that versus rotator cuff, they're not going to necessarily have weakness with a labral tear. They're going to be pain in certain provocative positions. Rotator cuff, if you think of how it comes over on the humeral head and attaches, when we're standing upright, gravity helps us pull that humeral head down a little bit. When you have a rotator cuff tear and then you lay down and take gravity out of the situation, that humeral head will ride up, touches the acromion there, and that's what causes that night pain because there's not that buffer of the rotator cuff.
Okay.
So it's a very classic sign.
Interesting. Okay. Any, I don't know if you want to talk through any specific maneuvers, different exam features that you would find for each one, kind of classic findings.
So for, say, rotator cuff bursitis, impingement is going to be more once they get up to that 90 degrees, it's going to be a little bit painful. Impingement, like the near Hawkins, you're going to feel that they're going to be painful there, but they're going to be able to move their arm. On an x-ray, you may see the acromion will have a little bit of a spur to it, which can cause that impingement as well. Typically with that, you're going to do the basic anti-inflammatories. You can do some physical therapy. You can offer a cortisone injection if you're comfortable doing that type of joint injection in the office. And ultimately, an MRI without contrast would give you a better indication of that area and what the rotator cuff looks like underneath that.
Okay.
Rotator cuff tearing, you're going to check the range of motion, but a lot of times it's not uncommon that they can have good range of motion with a rotator cuff tear. It's just you have to help them get past that painful arc. So if you're testing out here would be supraspinatus against resistance. External rotation, well, I don't know if you can see me, but external rotation is going to be checking the infraspinatus, coming out in front and having them press towards the belly while you resist. Is going to be for the subscapularis. Those are the three main ones out of the four that you're going to test for that are the most commonly torn.
Okay, great. In the labral lesions, tears?
Yep, labral is going to be more when you have them laying down, having them in that external abducted position here. They're going to have pain. A lot of times you can put down pressure here and it'll improve if it's an anterior. And then when you let go, it's going to pop up, and that's going to give them pain when it's more of that anterior. The upper part, called a slap tear, would be the superior labrum, where the biceps tendon attaches inside the shoulder. You're going to get that more with being out here with the palm up with resistance. A lot of times they'll complain of it reaching back because that puts the biceps in a lot of tension there.
Okay. You talked a little bit about imaging, kind of basic imaging compared to some more advanced like MRI imaging for each.
Yep. So typically calcific tendonitis, an x-ray would be enough that you could see it on there. Maybe a frozen shoulder adhesive capsulitis, that can be exam only. You're going to be restricted in more than one range of motion, and not just pain. It's going to be almost a hard stop, or they can't get there because of strong inflammation. Labral tear, not going to see it on x-ray, but a lot of times if you're going to get to the point of doing advanced imaging, insurance is going to require basic x-rays before you order that. Probably the biggest difference people will ask is, do I order it with or without contrast? Majority of the time, you're going to order just an MRI of the shoulder without contrast. The difference being the labral would be an MR arthrogram, where they actually put the dye in the shoulder joint. to look for that leak underneath the labral tear. So if you're suspecting a labral tear, then you'd want to get the dye.
Okay.
Put in again.
Anything else different for the rotator cuff?
Nope, that would be the, I mean, you could do x-rays. Definitely a rotator cuff, you can see x-rays sometimes if it's a chronic rotator cuff tear that someone's had for a while, because people can function with a rotator cuff tear. Everybody's got different pain tolerances. Maybe their other muscles have compensated and they're strong. But you'll see on a normal x-ray, the humeral head will kind of sit in inside the glenoid there. But you'll see if they have a chronic rotator cuff tear, that humeral head will start to shift up and it's not sitting. On a really chronic one, you can even see like a pseudo acetabularization up here of the acromion, because normally that's going to be a little bit flatter. You'll start to see that it takes the shape of this because they don't have the rotator cuff in between as a buffer.
Interesting. Okay. As far as management, I mean, so much of what they're learning is primary care management. So a little difference between primary care management and then kind of leading into that when to refer to sports medicine or orthopedics.
I would say you're never wrong in ordering a round of physical therapy, of consult. People will say that they do home exercises, but I think we can all say when there's accountability to it and documentation that it goes a long way. So, if they need activity restrictions below shoulder level at work, and that's something that they can still work and you can they can accommodate it, but they still want to keep working, offer them that to give a little bit more rest to the shoulder, but keep them in that working environment. An anti-inflammatory, a prescription one, it's never a bad idea if they've tried the ibuprofen and stuff to do something consistently for a few weeks to see if it makes a difference. Those are all things that kind of tease up what we would do if we see them right out of the gate. And whether or not you order the MRI, that's something we can always do as far as the specialized part of their care. But you can at least do the physical therapy, injections, and knowing that injections with a lot of things, if something's torn, it may not necessarily it's not going to heal it, a rotator cuff tear or labral tear, but it can offer relief while they're doing the physical therapy. Some people just say now is not a good time. So there is potential to offer them relief until it becomes the right time. And then if we were to order the imaging, an MRI or an MR arthrogram, either way your primary care provider does, the next step we would talk about with them is what would be surgical options if they failed all the conservative measures, taking into consideration, their age, their job, what their goal is after that. Not everybody's goal is to be the next Michael Jordan and play basketball again, right? It might be just getting back to work. It might be just getting back to my daily activities without pain. So knowing what some of their goals are helps guide offering what you have to offer them too. So.
Absolutely. As far as anti-inflammatories, do you have ones that you specifically like more than the other? What's kind of your experience with prescribing, side effects, the whole?
Everybody's a little bit different. I try and go with, diclofenac is a very common one that a lot of orthopods will use, 75 milligrams twice a day. But if someone is a I don't like pills kind of person, they're not going to take it twice a day. Might look at a meloxicam that can be once a day, like 15 milligrams once a day. They can take it in the morning with the rest of their pills, but they're never going to remember something at nighttime. Some people like to take something twice because they like to feel that they're taking something before bed to help themselves. So kind of looking at their personality, what they're looking for, can they take Celebrex? Insurance doesn't always like to pay for that right out of the gate. But if they're on blood thinners, if they, have GI upset with some of the other ones, then sometimes Celebrex can be covered. Otherwise, Voltaren gel went over the counter now, so that's always a good thing that you can offer someone if they're not a big pill person, but they want an anti-inflammatory. You can always offer them that topical option. Diclofenac over the counter now, which is nice too for the gel.
Yeah, some of your background is pain management, and so I don't know if you have a specific acute pain management strategy for patients that are really complaining of a lot of pain.
Typically what I'll try and do if someone comes in and they have, a fair amount of pain, say it's a calcific tendonitis, a lot of pain. There's nothing wrong with a short course of maybe tramadol being the strongest, but of course we, don't want to jump right to any kind of opioid agonists or, opioids, but doing like an anti-inflammatory, maybe a gabapentin or Neurontin to help them sleep. Or you start off with a steroid burst, something that's a little bit stronger to start, and then transfer them over to the anti-inflammatory by prescription. Those are usually some good options to try and catch it from a few different angles instead of just here's your pain pill or here's just your anti-inflammatory. And also reminding them that ice and heat, those are always options that people tend to forget about, but can offer a lot of good pain relief as well. So.
Great. Anything else that we need to talk about with shoulder specifically?
I don't think so.
Okay. Hips. I want to kind of touch on that a little bit.
Hips. Hips can be anything from osteoarthritis to labral tearing in the hip as well, because there's still that around the acetabulum. Acetabulum is like the glenoid of the shoulder is in the hip, so the ball and socket there. There can be dysplasia that doesn't present until early adulthood, that kind of thing. And then even stress fractures. Sometimes you'll see your healthy runners or someone that maybe fell that was older but didn't say anything, and they had a little bit of a stress fracture and kept walking on it. So those are probably the most common hip things you'll see. And then there's always the one that comes in looking like a hip, but it's actually from the spine or the thigh joint that can look like a hip pain as well. So classic osteoarthritis of the hip, you're going to have that front groin pain. They're going to have restricted range of motion. So typically I would have them sit at the bedside, do some internal, external rotation. And almost always, if it's a little bit more advanced arthritis, that internal rotation is going to be limited. You're not going to get much, to the point that people with end-stage arthritis have none. They're going to sit at the bedside, and as soon as you try and do internal rotation, they're going to lift their butt up because they're going to want to go with you, because otherwise it causes pain. So you can see, you just try and tell them to relax, and when you're trying to test that internal rotation, if it's painful or they don't have much, they're going to start lifting. They're going to go with you.
So just sitting on the exam table, rotating their
straight up, like
ankle
their ears, but you just have them sitting straight up. You'll kind of hold their thigh, and then I just grab by their ankle, do the internal, external rotation that way. External is usually preserved for quite a while, their rotation. It's the internal that's almost always a cue for that.
Okay.
And then if you lay them supine, you can kind of do the figure four, the Faber and Fader maneuver, where it looks like a figure four. They're crossing their ankle over the other knee. That usually will cause some pain in the groin if you're trying to rotate that as well.
Okay.
So that's probably the biggest key that I see is internal rotation loss with osteoarthritis.
Okay.
One of those kind of the wake up stiff in the morning, feel a little bit better, but if I walk on it for a long time, it starts to get a lot more sore, kind of that arthritis of almost any joint that happens. Don't really see swelling too much in the hip like you might with other joints with arthritis. Labral tearing usually is going to be more the athletic and the younger population. That's going to come in with that presentation, but it's going to be more with their hip in a flexed up position or like a catcher's position, deep squat. They're going to have pain, maybe some clicking, popping. And they'll almost always describe it as like a C shape. They'll grab their hip from the outside, kind of like a C, and say, I can't quite get to where the pain is. That's almost going to be your cue. Younger C-shaped type pain around the hip, that's going to be most likely a labral tear.
Okay.
Dysplasia, that one can be kind of tricky because they may just have this chronic come and go type pain. Depends on if they were athletes when they were younger or not. But most of the time you're going to catch that on an x-ray where it's just not going to look right, the ball and socket. And that's probably going to be something you might do a little bit of therapy for, because they're going to have a lot of muscular imbalances, but they're going to walk and look normal. They're not going to complain of a lot besides just kind of generalized pain. They won't have the clicking and popping necessarily. They might have some restriction of motion, but they're too young for arthritis. So, or any kind of impingement of the hip. And that's going to be few and far between, because it's usually caught younger when we see the kiddos. And most of the time they'll get to an orthopedic before it hits their 50s or something. So,
Okay.
And then fractures, those are definitely going to be your endurance athletes that tend to complain of that. Those are the ones you have to be careful of. Anybody that's super fit, super endurance, coming in with any kind of hip pain, foot pain, those kind of things, you have to think immediately like stress fracture. Did they increase their workout? Did someone that really wanted to go on a weight loss kick start doing a lot of working out from nothing, or significant increase with joint pain that worsens as they're doing their activity or after, and then rest makes it better? You have to worry about a fracture.
You're talking stress fractures.
Stress fracture. Yep. Different than if you just fell. Like an older person that falls or bumps something, you still have to worry like, yeah, it hurt a little bit, but now that I've been walking on it more, it's hurting even more. I would still worry about some sort of fracture there. Typically,
Sure.
the older person, if they're going to fracture, they're going to fracture all the way because of their bone structure being, osteoporotic or osteopenic. But just have that in the back of your mind with heavy endurance people, or people that are even trying to just get into working out and they go gung-ho and it's just not subsiding. You still have to think of that.
And generally they're walking in okay, and
they're generally walking in okay. The problem is the people that don't come in right away and they continue to work out on it because they have this race they have to do. Those are the ones you worry that they can completely fracture all the way across and really have a devastating injury if they can continue to do that. So you're never wrong in getting an x-ray to make sure you see something or you don't. And then you have to limit them. They don't like to hear that. They want to know what's wrong, but they don't want to do what's going to make it better. That's a lot of athletes. So.
Absolutely.
Yeah.
Imaging for the hip?
Yes. So x-rays for arthritis, if it's, stage 3 or 4 where it's, kind of that bone on bone getting there, you don't need an MRI. If someone's of age, you're not going to say a 20-year-old, but someone 50 plus that's has the end stage on x-rays, they have the lack of range of motion, never hurts to order physical therapy to gain some motion or, some prehab, even if they were to end up having a surgery. No MRI needed when it's arthritic. Okay. Labral tear would be something kind of like the shoulder. You're going to want to do an MR arthrogram. You put some dye into that joint so that they can see if there's a tear, they can see it better because the dye will leak through that.
One question about that, is that something generally you have to order through interventional radiology?
As long as the MRI place, it depends on the place that does the MRI, if they do arthrograms or not. Not every place does. The hospital does. And certain, if you were calling to do an MRI, you just have to ask them, do you do arthrograms there? Because yes,
Gotcha.
someone has to, a radiologist or someone has to put the dye into the joint. So, but if you're thinking labral, shoulder, or hip, you're going to put dye into the joint. Otherwise, an MRI without is going to be good enough. And a stress fracture, that's going to be good enough to do MRI without.
Is there any features with a plain film that would give you a cue that it might be a stress fracture?
Typically, if you use your contrast of light and dark on an x-ray, you're going to be looking at the femoral neck, and you're going to have a darker line on that femoral neck compared to the bone structure that you're going to look at. Another cue with x-rays, which is kind of at my tips point at the end that I was going to review too, always making sure you get more than one view of something. There might be a different angle. So if you get like a pelvic view, you want to compare that. So if you're doing hip, you probably want to do a bilateral so you get a pelvic view. Because is that an abnormal or is it just normal for them, depending on what it looks like, which is nice. Try and do a weight-bearing film whenever possible. If it's feet, knee, hip, that kind of thing, weight-bearing can definitely make a difference because that can collapse down any joint that you're looking at that may be a weight-bearing structure. So those are some of the features on X-ray. It'll highlight a little bit more there. There might be a little bit brighter white around it, edema in the bone. And you'll definitely see that light up if you did an MRI.
Okay. Anything else to cover on hips?
I think that's it. There's not a lot of red flags in the hip besides someone that's continually, the more weight I put on it, the more I do, the worse it is. And then when I sit down and rest, it's better. Of that athletic type person or working out, that would be probably my biggest worrisome that you don't want to leave go.
Gotcha. Okay. Knees.
Knees, there's lots in knees, but in general, arthritis is going to be one of the most common you'll see in the knees. Meniscus tear. Granted, there's ACL and PCL, but that's almost a whole nother lecture in and of itself of those different ligaments of the knee. But some of the main things like a patellar tendonitis or patellofemoral syndrome and gout would be one of those odd ones that might come in. Gout is going to be that sudden onset pain, can barely touch it, it's swollen, it's warm, I've never had this problem before, or it doesn't feel like my arthritis. That would be something that would, again, no injury, severe pain and swelling. It's either infection and redness, it's infection versus a gout. And best thing to do would be to take some of the fluid to send it off to the lab to look for crystals to differentiate that versus like an infection. If they had some sort of infection, do they have a fever? How are they feeling otherwise? Because gout, it's going to be all right there. If it's an infection, they're probably going to have more going on as far as not feeling as well, illness. Do they have some sort of bite or a cut or something that would have led to, a joint infection, not feeling
Sure.
well.
Do you use any of the lab evaluation when you're concerned about an infection, like any inflammatory markers or?
So you can do like the SED rates, CRP, the white blood cell count, and you can also culture the fluid you get off for crystals or look for that. You can also culture that to see if there's something that would be brewing that would help differentiate that too. Because the management of those will be different depending on if it's infection versus, a gout. You can treat with the medications. Infections, you're looking at referral to orthopedics, a washout, those kind of things. So that's going to be the rarer, fewer and far between, but definitely something if someone comes in, no mechanism of injury, severe pain, sudden onset, you're going to have to go down that route. But with meniscus tears, they can be a sudden onset or acute, depending on the injury, to just degeneration, wear and tear over time that can happen. So meniscus being the shock absorbers, they're shaped like two C's in the knee. So it's between the femur, the tibia. You're going to have the medial and the lateral. Most commonly torn is going to be the posterior horn or the backside. Usually some sort of twisting injury. So classically, they're going to have that joint line pain, medial or lateral, swelling in the knee that might come and go. If they have a foot that's planted and they twist on it, they're going to feel that pain, a deep squat. They're going to feel that pain on the inboard side or the outboard side. That's pretty much meniscus. I think the biggest thing is to really rule out, was there an injury or what was the mechanism? If it's on one side or the other, it's probably, going to lead you to that. Doing for physical exam, if they're laying on the exam table, you're going to do a full knee flexion. Do they have medial or lateral side pain? So it has to be consistent, on that side. And then you're also going to do a McMurray's, rotate that foot around and see if you can generate more pain on the medial or lateral side.
So there you're talking about rotating the knee, holding onto the ankle.
Yep. So the knee is in full flexion. You grab the ankle and you're kind of rotating it back and forth because you want to put pressure on that meniscus and see if you're irritating it. Typically, if someone has a meniscus tear, they're going to feel it in those positions. Flick test is another one you can do. That's not, I don't know about sensitivity and specificity of that test, but they're laying supine on the table. Basically, you have their hip all the way to the edge of the table. You drop their leg off the side. So they're, say it's the right leg, and you're going to flick the foot out. And usually you're in, and they're going to have pain on the medial or lateral side there, a little bit of irritation. Not any single test is going to say, yep, that's a meniscus tear, but if you can get a positive in 3 out of 5, the chances are higher that you're going to have a meniscus tear. Won't see it on x-rays, but you'll be able to see if there's any, joint space narrowing on an x-ray, and you would want to get an MRI of that knee to look for the meniscus tear. But be cautious, and while you document well, is there pain medial or lateral? And you're testing, because it's not uncommon that you may get the MRI and they might have a tear on the lateral side, but that's not where their pain was. So nothing worse than not matching up. Oh, yep, knee pain, got a meniscus tear. You send them somewhere potentially. And then they come in and their pain is all medial, but yet it was a lateral meniscus tear. That wouldn't coincide. So you wouldn't want to offer someone surgery for that, because their pain's not going to get better if you're not addressing something on the medial side. So just documenting carefully, like where they're complaining subjectively of pain, what are their objective findings in your physical exam, and then reminding yourself, like I'll put in my note, MRI of the right knee to better assess for medial meniscus pathology. So it tells me exactly what, or if someone's looking at that, what I'm thinking and what I'm looking for. So if it comes back with something different, then that will tell you which route you want to go for as far as your treatment plan.
Yeah, I don't know if you can talk specifically with meniscus kind of prognosis too, like non-surgical repair compared to surgical repair, because I know that's something that sometimes can be managed in primary care depending on patient choice too.
Correct. So meniscus tear, I would say majority of adults, just like rotator cuff tears, if you MRI'd a bunch of people symptomatic or not, some of them are going to have meniscus tears, some of them are going to have rotator cuff tears, but they may not be complaining of things, right? And so meniscus tears depends on what aspect it is. But once you have a tear in the meniscus, there's different types of tears. It essentially, the fibers that run in the meniscus, it's going to be non-functional, okay? So whether it's meniscus tears there and you don't do anything about it, it's a matter of your pain. Because when we go in surgically, if we're going to trim that meniscus or do a meniscectomy, see me? So if this is a meniscus and there's a tear back here, the meniscus is C-shaped. It also is wedged. So it's fatter on the outside and then it comes down to a point. So if your tear is most likely on the skinnier point back here, we're going to basically go in and trim that back to be a skinnier C shape and take that tear out. So because where it's torn is no longer functional. It's just a matter of if it's bothersome to you, whether you leave it in or you take it out. In the long run, a non-functioning meniscus, whether it's torn and you leave it or you take part of it out, in the long run, not a certain amount of years, it's hard to say, but 20, 25 years, you will definitely have a precursor or an increased risk for arthritis of that aspect of the knee joint, because your shock absorber has decreased. You have less of your shock absorber. So meniscus tear, if you see in typically in a younger population, a high school athlete, college, they're going to do everything in their power to try and repair that. If it's in the proper zone of the meniscus that has good blood supply, because they're looking at 20 years old versus 30 years from now. We don't want to set someone up for a knee joint replacement if we don't have to. We want to try and preserve that joint as much as we can.
Okay, great. I don't know if there's any other common knee pathology that you want to touch on.
Like patellar tendonitis, patellofemoral, IT band, kind of all that Generalized patellofemoral syndrome is going to be that kneecap, behind the kneecap pain. A lot of times it will be runners that will have pain there. A common finding on exam will be that actually the counterbalance is going to be your hamstrings. So tight hamstrings will lead to some patellofemoral pain. So that's one of the first things. If you send them for physical therapy, they're going to work on hamstring stretching and quadricep and hip internal external rotator strengthening. With any patellar pathology, just because our quadricep muscles turn into that quad tendon, and that attaches at the top of the patella, and then the patellar tendon at the knee will attach at the tibia and the bottom part of the patella. So that's really your extensor mechanism to make your leg go up and down. So you need strong quad muscles and not an imbalance to really have that kneecap or the patella track appropriately through its range of motion. That trochlear groove in the femur. And it just takes a little bit of weakness, and that can really kind of wreak havoc there. So patellar tendonitis, patellar maltracking, IT band, those are some of the common things that you'll see in some of the athletes as well that are not muscular balanced well enough. Physical therapy can even do some patellar or McConnell taping with kinesio tape and stuff that can really help symptoms as far as keeping the athletes in the game. Women like volleyball and those kind of things that you can't have a big knee, bulky knee brace. If they're wrestling, you can't wear a knee brace. Those
Sure.
kind of things. So that's always a good option as well, that physical therapy can help teach how to do it yourself.
The other one I think sometimes you see is patellar bursitis.
Prepatellar bursitis? Yep. So prepatellar bursitis is going to be pretty much walking in the door. You can usually tell it just because it's going to be like the olecranon bursitis of the elbow. They just have a big ball of fluid right there. And on the knee, they're going to have fallen on it or some sort of traumatic, usually, or a carpenter or someone a flooring person that works on their knees all the time. And it's just going to be a big balloon right in the front of the knee. So just sitting there, if they have shorts on, you're almost going to see the difference in that seated position because it's going to stick out. And you can drain them, but you just have to be cautious because a lot of times they'll just fill back up with fluid. So compression, resting it, icing, elevation, those are going to be the biggest things for like a prepatellar bursitis, definitely. The difference with that swelling for prepatellar, you can see it from a mile away versus intra-articular or within the knee joint. That would be a difference that you'd want to document as well. So typically, prepatellar, you're going to see in front of that patella. Suprapatellar, if you have swelling up there that you can push on and it seems like a water balloon, and if you push above the knee or the patella on the knee there, it's going to almost seem like a water balloon, like you're pushing it around, because really essentially you are within the knee capsule. That's going to be fluid within the knee joint, and that's always abnormal if you can feel it. We always have a trace of it if you do an MRI, but it's not something you should feel on exam normally. So if you have fluid within the knee joint, it usually means that there's either meniscus pathology, a fracture of some sort, and it's blood, a ligament, like you tore your ACL, which again, that's going to be an acute problem with blood, or like articular or cartilage issue, arthritis. So fluid within the knee joint is always abnormal if you can feel it on exam. It doesn't mean it's an urgent referral. It just means there is something going on, and you have to distinguish that between the rest of your exam of what it's coming from. So.
Okay. Yeah, I don't know if we need to touch any more on imaging of the knee.
Pretty much the x-ray is going to tell you if it's weight bearing. That can really close down and see someone's shape if it's valgus or varus. If you get a standing x-ray, those are important for upright because that can really show you the narrowing of the joint spaces, medial and lateral. The difference of non-weight bearing versus weight bearing. And if they're not weight bearing, the first thing we're going to do in orthopedics is get weight bearing to see what that joint space is. So that's helpful. Otherwise, MRI is going to be your go-to, MRI without contrast typically.
Okay.
The knee.
And anything as far as management, bracing comes to mind, physical therapy.
Bracing is good to a degree, depending on what the problem is. So a lot of patellar stuff you can brace. They work well for people for patellar maltracking, patellar tendonitis. There can be a little bit of a brace to take some of that pressure off, kind of like a tennis elbow brace strap. For arthritis, I don't know how many primary care providers are comfortable, but you can do an unloader brace, they call it. But you can actually, it's a little bit cumbersome for people, but if they can wear it, it has to be against the skin. So they can't wear their skinny jeans with it. But it's meant to put pressure on the opposite side of the joint to open up the narrow joint. So it unloads the compartment that's narrow because of arthritis. It is meant to put some pressure there to open up that joint on the opposite side. And some people, they love them. They last for a certain amount of time, depending, just because progression of a natural disease process like arthritis is going to happen. But it's definitely a conservative treatment option that people can do. Injections, steroid injections, there's hyaluronic acid injections. So that you flex the syndus. Trying to think of the other ones. Monovis, any of those that can be every 6 months. Steroid injections, but most orthopedics, if they are an osteoarthritis candidate for potentially a total joint replacement or even a partial, most orthopedics will not do that surgery within 3 months of their last injection, no matter what you inject, because of increased risk of infection. So something just to think of if someone says, I just need a steroid injection to get me by until I can get surgery at the end of the year. Just be mindful that most of the time they're going to want 3 months before they even do surgery. So don't offer them that like a week before they're going to come to see the orthopedic doctor to discuss potential, arthroplasty of a joint.
Absolutely. Okay. Good. Anything else to discuss with knees?
I don't think so.
Okay. And how about the back?
Oh, the back. I have a lot of history with back because I did the pain management before orthopedics. So a couple tidbits on back is always looking at that person that comes in and says, I didn't do anything. I don't have a mechanism of injury, but I have this severe back pain, right? Those are the people that you go, I can't really explain that. Those are the ones you want to think of like kidney stones, pyelonephritis, something other than true spine stuff. Most spine stuff, if it's just back pain, does not just come on with no mechanism. I would be thinking of other, what do they call them? Zebras, unicorns, weird animals. If they're coming in with severe onset of pain, back pain without any injury at all. And most people, the first thing you can ask them, have you had back pain before? And is this your normal back flare-up? People that have chronic back problems, they can tell you if this is their normal type of flare-up, if this is different than their normal back pain, and you can trust them on that because they'll be able to tell you. So you look at, do they have a fever? Do they have an injury? Are they having any problems with urination? All of those things that can cue you into something else going on. Obviously, there's another zebra. If you have someone with IV drug use, you have to think of infection, osteomyelitis. An older person that fell and has severe back pain, you have to think of fracture all the time. Vertebral fractures, obviously x-rays can help you with that. X-rays can also help you with looking for the kidney stones too. Typically can show up on a basic x-ray. So the other thing with spine really is kind of looking at, do they have back pain or radicular pain, meaning, down one of the dermatomes, and specifying where. Don't just say back and leg pain. It's very helpful if you could say they have back pain that progressed to buttock pain, lateral thigh, anterior shin, into the top of the foot. That follows a certain dermatome, and that really kind of cues you into what you're looking at in the spine. If it's both sides, then you're thinking something more central spine related. Central stenosis would be one that's very common. I feel better when I bend over. It's the grocery cart, leaning on that. I need support. I can only walk so far, and then I have to sit down because my legs feel tired. But they don't describe pain in a certain pattern down the leg. Those are the things you have to kind of your algorithm of what you're thinking of. Back pain only, sudden mechanism of injury. If it's chronic back pain, just always there, you're thinking more the facet joints, the chiropractor that does the snap, crackle, pop, that can help with that. Any back pain is going to be recommended to have a stronger core, and working with that as far as the spinal stabilizers there. If it's unilateral leg pain versus bilateral, that's helpful. If it's a specific pattern, the description of the pain, achy, burning, unrelenting, doesn't go away. If they can't get comfortable with it from a certain position, you might be thinking other than back, because most back pain, they can find a comfortable position at some point. They might be draped over their ottoman to find a comfortable position if they have a disc herniation, but they can usually find something that brings relief. Kidney stone people are all over the board. They can't find any relief. So some of the red flags for back pain: always ask them if they have any kind of weakness in their lower extremity, dragging their foot, can't lift their thigh up, bowel or bladder incontinence. People will not tell you about that because it's embarrassing. So even if you see someone for back pain and you're concerned about it, telling them, if you have bowel or bladder incontinence, you don't have the sensation and the urge to go to the bathroom, and you just do, that's a red flag. Do not be embarrassed. You need to see someone about that. Or same as if they get saddle anesthesia, which is around the private areas. Basically, I tell them, if you get completely numb in the distribution of like your underwear, that's a problem. It's not an embarrassing thing. And when you bring it up to them like that, to let them know, like, this is something to be talked about, they're usually pretty good to say, no, I haven't had that. But those will be the red flags that says, do not pass, go, like, whatever it is. Go to the ER, because that's going to be more serious. That needs to be evaluated more urgently. And always documenting that they don't have those is important. So.
Absolutely. Specialty exam findings that you would note?
So normally the range of motion, bending over at the waist for flexion, extension. Another thing is rotational extension. That's going to put more pressure on the facet joints. If they lean forward and they feel relief, it could be facet joints, but that's spinal stenosis. Looking at reflexes to see if they're decreased on one side versus the other. So you always want to compare it to the good side, because you never know, and that's any side, any joint that you're evaluating. Evaluate the other side, because something that seems abnormal might just be their norm, right? If they're restricted of certain range of motion or a certain way, they may have it on the other side and it's not a problem because that side doesn't hurt. So I always compare it to the good side to see what we're working with. Straight leg raise, pretty classic. If you have them straight, lift their legs straight out in front of you, pull their toes to the nose, lean over. If it's a disc herniation down the leg like that, they're not going to be tolerating that for very long and not happy with that. If you think of a disc herniation on the spine, on the side, so central stenosis is going to be in the center. On each level, there's going to be foramens that come out, and those where the nerve roots come out. So if they have foraminal stenosis, that's where you're going to get the pain down the leg on one side or the other. And typically, if they lean towards that side that might have narrowing or disc herniation on one of those nerve roots, when they lean towards that side, they're going to have an increase in their symptoms because they're compressing that space. And if they lean to the other side, they're going to be opening that space. So if you walk in and someone is sitting in the chair with their legs straight out and they're leaning the other way away from it, coming in with back pain, you can kind of discern that they're probably going to be a disc herniation because they're trying to stretch away from it. Their leg is straight out. So those are some keys on physical exam that can be helpful.
Okay. Imaging?
Imaging, x-rays, obviously to start with on a lot of those, especially the sudden back pain, I had a fall. You always want to rule out the fracture of the spine stuff. MRI is good as far as just an MRI without contrast, unless you're looking for any sort of cancer history, then they're going to do it with and without IV, typically contrast. Physical, well, that would be for imaging. Physical therapy, anti-inflammatories, those are going to be all the things. A steroid first to kind of get them over that hump. Maybe like a nerve pain medication, gabapentin, if it's a true radiculopathy or a disc herniation. That can be helpful to counteract as well without jumping right to the opioids. If they're that miserable, then it's up to, providers' discretion. But I always try and roll out everything else that could be helpful first, right?
Absolutely.
Physical therapy. My understanding still is that physical therapy for like a disc herniation, at the end of a year, whether someone goes in and has part of that disc removed, a discectomy, a year later versus no surgical treatment, their outcome is about the same. It's a matter of what you can tolerate in the meantime and how severe that pain is. And size does not matter on the MRI findings, because huge disc herniations could cause semi-minimal symptoms, and a small disc herniation, if it's, from a microscopic level, causing enough irritation to that nerve by what it gives off, can cause severe symptoms. So sometimes it's not because they have, a small disc herniation. It's a matter of how irritated is that nerve that really causes the pain. So, and that can be found on the MRI.
Good.
So,
anything else on back?
Steroid injections can be an option, something you're not going to do, but I know that was a question from one of the students.
Correct.
That's something that you're going to send out for interventional radiology, pain management, or physiatry to do those injections. Typically, I would let them decide what they think is best. Because even if someone has, say, central stenosis at a certain level, steroid injections can help those people tremendously. The problem is if they're really stenotic, you're not going to put the medicine right at that level. So it's common that you'd say, well, aren't you going to put the medicine at L3-4 because that's where it's most stenotic, when actually you can put it above or below, and it's going to travel in that epidural space and still provide relief. But you don't want to put more pressure with that fluid where there's already stenosis. So it kind of, that provider that does the injection would review the films and decide which approach is going to be the best. But you can do it for central stenosis. When there's that foraminal stenosis on the nerves coming out from the side, they can put it right there as well to help reduce some of that swelling and irritation to the nerve. So that's either going to be a nerve root block, is what they call that, because they're blocking it at the nerve root coming off the side. Or they may call it like a medial or lateral, a medial paraspinal epidural steroid injection. But they'll guide it based on what they feel based on the images.
So is that more of an orthopedic, or is that a pain management referral, or is that more of
usually physiatry or pain management? They're definitely more the spine people. I'm trying to think. Nobody in our office does epidurals for sure. We don't typically treat the spine stuff. We may see it and walk in and then refer it to our partners after we've done some of that conservative treatment if they need surgery. But there are some, no, I would say spine, referring them to physiatry, pain management, spine locally.
Okay.
Yep.
Okay. A couple of other things that we kind of talked about, Salter Harris. I don't know if you want to address kind of your basic things with Salter Harris.
So for fractures, those are always fun. Because I did a lot of sports medicine first in my first practice before I came here, and we didn't take falls, so we didn't do a lot of fractures in that sense. So I definitely had to kind of learn as well. But Salter Harris being the acronym for Salter can kind of help you with that, of the different types. Obviously type 1 and 2, not as bad. As you get to 5, that's a little bit worse. So it's a matter of the growth plate. Are you just going through the growth plate like type 1? Are you above the growth plate, like through it and above that growth plate? That's going to be, type 2. Through it and lower is going to be your L for Salter, so that's going to be type 3. 4 is going to be more transverse through it, and then 5 is going to be through top bone, bottom bone, and through the growth plate. So type 1 and 2 is probably the most, type 2 is going to be the most common you're going to see. Type 1 and 2 above is going to be your best prognosis, best outcomes. If it goes fractures, the big thing is if it's pediatric, if it's through any growth plate as a pediatric, you're going to want to refer it to ortho to manage that and follow up with them. The other thing with those fractures, the big thing is displacement, how much it's displaced. So if something fractures but it's lined up really nice, many of times it can heal with restriction of the motion at that joint, giving it time to heal. There's a couple of those that you still want to have probably ortho look at. But displacement, and a good way to know displacement is x-rays can fool you. So if you get just one view, it looks beautiful. But if you get a lateral view, maybe you'll see that it's displaced. So it's definitely in the plane of what you're looking at. So you always want to get more than one view of whatever you're x-raying, because it may look lined up on one but not the other. So that's probably a good tip, is that you never want to just get one view of an x-ray for something with concern.
Sounds good.
The other thing is that it never hurts if you're questioning if there's a fracture on an x-ray, but you're not quite sure. Then you're probably safe in doing an immobilization or activity restriction of that joint, having them come back in 7 to 10 days, re-x-ray it, because that's what it would take for some growth to start if there was a fracture. Or if sometimes they need that to present once swelling's down and stuff, you may see a fracture a little bit more evident on a follow-up x-ray. So close monitoring, activity restriction of that joint, if you're unsure, is never a bad thing.
So if you gave them instructions, if this pain, the initial x-ray looks okay, if this pain is not any better within 1 to 2 weeks, if they have them return and re-x-ray would be a good idea.
Either way, typically I do, because I don't know how compliant they've been with non-weight bearing or activity restriction. So I usually have them come back so that, say, to re-x-ray it, yep, it looks good. Now, can you weight bear without pain right now in front of me? What is your range of motion now that you've lived with this? Because some people are very hesitant to want to let you do range of motion and stuff when something hurts, right? So you give them a week, they've had activity restriction, maybe some anti-inflammatory icing. They know it's probably getting better, so they're going to let you do a little bit more, and you can truly see how much better are they. So I typically bring them back in 10 to 14 days, re-x-ray them, really see what the physical exam shows different than the first one, to cover your basis, and go from there. Because maybe they were actually weight bearing in the beginning and something displaced, but then they stopped doing it. So they're like, no, it's better because I didn't go on it, but they could have done something. So depends on compliance too.
Sure, absolutely. There was a question about kinesiology tape.
Yep. So for a lot of times, kinesiotaping, I think is good for like a lot of the knee, patellar femoral, patellar tendon, those kind of structures. I had my own experience with it after my ankle surgery this summer. I fractured and had to have surgery, and 6 weeks of non-weight bearing, you can atrophy quite a bit. And so my foot actually getting out of, when I first started weight bearing, it was almost like a foot drop. It was really weak with my calf muscles. And as I started to progress with that, part of my posterior tibial tendon was still weak from the inside damage, so on the medial side of my ankle. So anyways, he can kinesiotape in the arch there, and I actually could feel a little bit of a difference when that came off and stuff. So I think for the right purpose, it can be very helpful. So I'm never opposed to something like that because it's not going to hurt anything. If a patient wants to try it or they say, hey, it really helps, have the physical therapist show them how to do it themselves. You can buy that tape and, McConnell taping, and they can figure out how to do it. Sometimes for certain shoulder pathology, taping can kind of help. So I'm never opposed to something that's not really invasive for someone to try.
Sure. Yeah, that was the other, one kind of more holistic management strategies, non-invasive, non-medication.
So I would say the hardest one for people is going to be the activity restriction. To truly rest someone or have them rest the body part, we are just a go, go, go society. So it's very hard to put someone non-weight bearing of an ankle and truly be non-weight bearing. I've done it. It's not fun. And it's really hard, especially if you're crutches. How do you carry? I couldn't even carry a cup of coffee to my living room. I could make it, but I couldn't get it. So, you have a knee scooter, and how can you help them do what they need to do to heal or to get better? So, like I said, if it's activity modifications at work, okay, I don't want to take you out of work. We want to do everything we can to keep people working. But can we limit your overhead activity while you're at work for the next few weeks, just so you're working at like chest level and below? That will give that shoulder a rest, but yet they're still at work if that's something they can accommodate. Ice, the heat. I can't stress that enough, that people do not give it enough credit and actually consistently try it. And elevation, be cautious, because when people say they elevate in a recliner with their feet kind of hanging down, just because they're off the ground does not mean elevation, right? So elevation is truly like you're on the couch and your leg is up if it's your ankle. Or if we're telling you to elevate, I really want it to be up, 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 as much above the heart as you can. I truly think people sometimes think just getting their feet off the ground is elevating their legs. And that goes more than orthopedics, right?
Mhm.
And it kind of
Absolutely.
vascular issues and, compression stockings, those kind of things.
So you are not a lazy boy elevation advocate.
I am not, unless you have a bunch of pillows on that lazy boy underneath the body part that's needed to be elevated.
Sure. Okay.
This is coming from I had minimal swelling in my ankle or my toes the day I had surgery because I had 3 days of elevating that puppy. I pretty much slept with it in the air. Mm-hmm.
Okay. All right. Good. I like the lazy boy reference too.
Yeah.
Okay.
What else can I say? Ooh, some tips for fractures healing just in general. Do we do NSAIDs or not? Every surgeon's a little bit different. Fractures, obviously, there is some inflammatory response you want for healing. So to just nail it with a bunch of ibuprofen, I guess I'd be resistant to that. Here and there for some pain relief, but as your primary pain reliever, probably not. That's where elevation. I can tell you I took minimal pain medication after my surgery and before, because I was truly non-weight bearing. It was in a splint. I took Tylenol, I used ice, and I had it elevated, and it did what it needed to do. So from that conservative standpoint, there's a lot you can do. And probably part of it just being the mindset that said, I don't want to have to take them. Stubborn. But if they can minimize that with like a fracture, great. But if it's a surgery or an injury that you can take ibuprofen or leave, absolutely get them to do around the clock anti-inflammatories for that first week or two to really help decrease some of that and help with the swelling and the pain. Kids, you definitely want to do more of the ibuprofen Tylenol versus any Tylenol codeine and those kind of things for pediatrics. And many people will ask you, is there things I can do, certain things in my diet, pills I can take to help speed up the healing process? And I guess my biggest information back to them is there's not a lot we can do to speed it up. That's Mother Nature with a lot of what we're doing. But there's things you can do to slow it down. So poor diet, malnutrition, even if people are overweight, they could still be malnourished. So good protein, good fluid intake is going to help as far as healing, getting good rest, those kind of simple measures. But diabetics, they are known to have poor wound healing. So keeping that under control. Smoking is a huge huge contraindication for good healing. Certain surgeons, depending on what it is, they make you quit smoking in order to do some sort of fusion, bony, rotator cuff work because it can really hinder. So if they can say, is there anything I can do to help the process? If they're a smoker, number one thing is to quit smoking for that and many other reasons. But continually not following the activity restriction would be another thing that they could do to slow the process, right? If they're not following those guidelines, then they're risking it not healing properly, no matter what it is. So can't really speed things up, but you can definitely find ways to slow it down. So
in your experience, you really find it important if you're using Tylenol or an NSAID to have it scheduled and to use it scheduled initially, correct?
I think the biggest thing is that if people don't try to be preemptive about it or consistent, they kind of forget about it. So I try and have it scheduled, and at least if it's a pain, you're trying to avoid narcotics. A good thing with ibuprofen is Tylenol is you can alternate that schedule so they feel like they are taking something, but it's still safe every few hours. So they don't feel like they're stuck for 8 hours before they can take more ibuprofen. And now they're having pain at 6 hours. What do I do? So to alternate that, I think is a good option for them. Even the mental aspect of taking something or feeling like they're doing something, or, okay, at least every time you take your Tylenol, I want you to be icing. That at least gets them to ice 4 times a day then, if they're doing that, is a good option.
Okay. And you have a number of things that just kind of tidbits and things that you wanted to share with the students.
Yeah, so I have my notes. I kind of covered them throughout the lecture as well. Always getting more than one view of the x-ray of a body part, especially if you're considering a fracture of any sort, just getting a couple of views at least. Never hurts to activity restrict if you're questioning a fracture somewhere that's not obvious on an x-ray, and re-x-ray them in 10 to 14 days just to make sure. Standing or weight-bearing films whenever possible for feet, ankle, knee, hips, x-rays. Don't do weight-bearing for shoulders because they'll look at you. But it's always helpful because in the long run, if you're going to refer them out, then that's very helpful for the other people that have to see those x-rays because less exposure, the best. When in doubt, I guess refer it out or give a call to ortho and have them take a peek. They never mind looking at a film and saying, no, I think it looks good, or I would just monitor that. And knowing what you're comfortable with as far as joint injections, if you're comfortable with them or not. And then, different splinting and casting that comes with some of those fractures. That's definitely something that's a learned trait, I think. And most of the time, it's honestly not us that's doing it. It's your medical assistant or nurses in the office that are doing that. So knowing who is your resource for good casting and splinting and those kind of things if needed.
Good. All right. Anything else we should touch on before we wrap it up?
I don't think so. I think there's always that worst case scenario and making sure you know what that would be as far as documenting. When it comes to an orthopedic or sports medicine, I think for documentation purposes, it's really important to document the mechanism of injury, how it happened, a date, if they have a specific date. I don't say last Friday, I say on this date, just because that medical records can come back to haunt you. And if you see them first and then they come to me, if they're claiming work comp, they're going to go all the way back to your records. So it's really important for everybody to be on the same page. So when did it happen? How did it happen? I get as detailed as possible. And if they say, I don't know how I landed on my ankle when I twisted it, I say they're unsure how they landed, but they think they had an eversion, inversion, injury, those kind of things. Did they feel a pop? Could they weight bear right away afterwards? Or could they lift their arm if they fell on their, outstretched arm? And then I just kind of document the progression of it. This is how it started, but it's gotten worse. It's gotten a little bit better, but not good enough that they came in for an evaluation. Kind of that timeline that speaks to that. And have they ever had a problem on the site with that body part before? Is this a reoccurrence? Is this a first-time thing? Because it might be the first time of many to come, and then you have that well documented too.
Great.
What's their range of motion that you can give it? What can they give it for active versus passive range of motion of a joint? Are they neurovascular intact? Numbness, tingling, pulses. If those things are all normal, you're probably pretty good. Not going to be sending them to you in the urgent care.
Okay. Well, good. Well, thank you so much for doing this. I
Yeah.
greatly appreciate it.
No problem. I feel like that's kind of all over. So if they think of more questions, we can follow up.
Absolutely. All right. We'll go ahead and end the recording right now.